Vitamin D is a fat-soluble vitamin that plays an important role in calcium homeostasis and bone metabolism. Vitamin D deficiency can lead to osteomalacia and rickets in children and osteomalacia in adults. The fortification of milk with vitamin D in the 1930s was effective in eradicating rickets in the world. However, subclinical vitamin D deficiency is still widely prevalent in both developed and developing countries, with a worldwide prevalence of up to 1 billion. This subclinical vitamin D deficiency is associated with osteoporosis, increased risk of falls and fragility fractures. Many conflicting recent studies are now showing an association between vitamin D deficiency and cancer, cardiovascular disease, diabetes, autoimmune diseases, and depression. Causes of vitamin D deficiency. 1. Decreased dietary intake and/or absorption. Certain malabsorption syndromes such as celiac disease, short bowel syndrome, gastric bypass, inflammatory bowel disease, chronic pancreatic insufficiency, and cystic fibrosis may lead to vitamin D deficiency. Lower vitamin D intake orally is more prevalent in the elderly population. 2. Decreased sun exposure. About 50% to 90% of vitamin D is absorbed through the skin via sunlight, while the rest comes from the diet. 20 minutes of sunshine daily with over 40% of skin exposed is required to prevent vitamin D deficiency. Cutaneous synthesis of vitamin D declines with aging. Dark-skinned people have less cutaneous vitamin D synthesis. Decreased exposure to the sun, as seen in individuals who are institutionalized or have prolonged hospitalizations, can also lead to vitamin D deficiency. Effective sun exposure is decreased in individuals who use sunscreens consistently. 3. Decreased endogenous synthesis. Individuals with chronic liver disease such as cirrhosis can have defective 25-hydroxylation, leading to deficiency of active vitamin D. Defect in 1-alpha-25-hydroxylation can be seen in hyperparathyroidism, renal failure, and 1-alpha-hydroxylase deficiency. 4. Increased hepatic catabolism. Medications such as phenobarbital, carbamazepine, dexamethasone, nifedipine, spironolactone, clotrimazole, and rifampin induce hepatic P450 enzymes which activate degradation of vitamin D. 5. End organ resistance. End organ resistance to vitamin D can be seen in hereditary vitamin D-resistant rickets. Treatment of vitamin D deficiency. Initial supplementation for 8 weeks with vitamin D3, either 6,000 U daily or 50,000 U weekly, can be considered. Once the serum 25-hydroxyvitamin D level exceeds 30 nanograms per milliliter, a daily maintenance dose of 1,000 to 2,000 U is recommended. A higher dose initial supplementation with vitamin D3 at 10,000 U daily may be needed in high-risk adults who are vitamin D deficient, African Americans, Hispanics, obese, taking certain medications, malabsorption syndrome. Once serum 25-hydroxyvitamin D level exceeds 30 nanograms per milliliter, 3,000 to 6,000 U per day maintenance dose is recommended. Children who are vitamin D deficient require 2,000 U per day of vitamin D3 or 50,000 U of vitamin D3 once weekly for 6 weeks. Once the serum 25-OD level exceeds 30 nanograms per milliliter, 1,000 U per day maintenance treatment is recommended. According to the American Academy of Pediatrics, infants who are breastfed and children who consume less than 1 L of vitamin D fortified milk need 400 U of vitamin D supplementation. Calcitriol can be considered where the deficiency persists despite treatment with vitamin D2 and/or D3. The serum calcium level shall be closely monitored in these individuals due to an increased risk of hypercalcemia secondary to calcitriol. Calcidiol can be considered in patients with fat malabsorption or severe liver disease.